Okay, this is it. This is the last lecture on Team 3. This is the last Team 3 lecture, and I was asked to talk about my favorite topic, pulmonary embolism. So I'm going to say a few final words on pulmonary embolism. Making the diagnosis, you risk stratify in the likelihood, okay, and the CTA is really the diagnostic test of choice. Um, there are different criteria you could use to determine the likelihood of PE. If you have a high probability, you're going to go right to CTA. If you have a low probability or an intermediate probability, you're going to have a D-dimer. D-dimer has to be age adjusted. 10 times your age is the low normal. So an older person, you're going to have a higher threshold to evaluate. There's certain rules like the PERC rule where if you're under age 50 and you have no criteria, then you don't even need to get a D-dimer because most of the time D-dimers do not lead to diagnosis. But assuming you make the diagnosis, this is something that you have to deal with right away and want to risk stratify. Okay, so we used to call this massive PE, submassive, and non-massive. And now it's kind of called high risk, intermediate risk, and low risk. And then intermediate risk is two categories, intermediate high and intermediate low. And then there's something called catastrophic. So a catastrophic PE is the patient's near death. They're in cardiac arrest or they need ECMO right away. And really the mechanism in this is mechanical. If you have huge obstruction, you can't get blood from the right side of the heart to the left side of the heart. You're not going to get any blood out of the left side of the heart. A massive PE, you have a low blood pressure. It's hemodynamic compromise. That's an emergency, okay? Submassive is their blood pressure is normal, but they have markers that indicate that these patients will do worse, okay? And either via imaging, and that's where an echo is helpful, okay, or an elevated biomarker like a troponin. So the imaging, an echo would reveal something called McConnell's sign, where you have an RV hinge point where the RV apex moves normally, but not the RV free wall. Okay, that you see with PE. More sophisticated, there's something that the echocardiographers do called a TAPSE, tricuspid annular pulmonary systolic excursion. And you could also look at the CAT scan and the RV-LV ratio on the CTA if it's greater than or equal to 0.9, especially if it's new, that's abnormal. The big biomarker is a troponin. Okay, you could get right ventricular infarction with pulmonary embolism. Now, if you have both of these, that's PE intermediate high risk. If you have one of them, that's PE intermediate low risk. And then you have non-massive, and a lot of these people now could go home. You don't need to be admitted with a pulmonary embolism. So rule of thumb, massive is 10%, maybe a little less. Submassive, 20, 25%, like 70%. Non-massive. So real quickly, what are you going to do? You're going to make the diagnosis of PE. Somebody has a massive PE. There's really a game changer. This came out within the last 2 years, the FLAME trial. Basically, with massive PE, they're getting thrombolytic therapy. There, the benefit outweighed the risk. Now they're doing percutaneous catheter thrombectomy and removing the clots, and in the institutions that have that, that's the way to go. And they're doing these procedures in the intermediate high-risk people also. Initially, they were given catheter-based lysis, ultrasound delivered catheter-based lysis, and it showed better hemodynamics acutely. There were trials, the ultimate trial, Seattle 2, the Optolice trial that showed these things were better. But now with catheter, and they have all these different catheters, a lot of this is becoming an interventional game. Non-massive, they're going to be sent out, and especially if you can, and the drugs you can start right away are Eliquis, okay, or Xarelto, apixaban, rivaroxaban, and somebody's low risk, they could be sent home. That's basically how you handle this. Now, if somebody's really sick, obviously they're going to be admitted, and if they have a intermediate risk, PE, they need to be admitted. You don't send them home because these people have a risk of deterioration, acute deterioration, PE death overall. So you're not going to send them home. Somebody with a PE who clearly, they don't have hemodynamic compromise, they have normal hemodynamics, not high risk. If it's the right person, you can send them home. What other questions might you have? Just throw me a question before I wrap up.
You could talk about duration of anticoagulation.
Okay, how long do you anticoagulate? A lot of this has changed. Somebody is a reversible risk factor. Usually it's 3 months, maybe 6 months. After that, if somebody has a VTE, DVT, or BE, and you don't know the reason, this is a chronic disease, and it comes back about 30% over 7 years recurrence, 40% over 10 years. The feeling is you're going to anticoagulate. Now, what you're going to do is after 3 to 6 months, you're going to lower the dose. Okay, you're going to lower Eliquis to 2.5 BID, and you're going to lower Xarelto to 10 milligrams a day. But it's longer, and maybe that'll change in the future. And they're not doing multiple high risk, therothrombophilic studies either. If you suspect cancer, you want to diagnose that. But a lot of these other people, you're just not. You're just going to anticoagulate them. Question for you.
I guess, what further workup do you do for people that are non-provoked, you can't find a reason?
Well, if you can't find a reason, it's been shown the two most common thrombophilic states are factor V Leiden and the prothrombin gene mutation 20210A. These people don't have a higher risk of a second clot compared to somebody who doesn't have them, and it's not going to change what you do. As far as a cancer workup, you want to make sure they have the routine cancer screening. Now, the tumors most commonly associated with PE, pancreas, and stomach cancer, but it's not really recommended that you image patients for that. So the answer is you can do H&P, blood work, and make sure they have routine cancer. And in certain type patients, if you're concerned about the antiphospholipid antibody syndrome, that's lupus anticoagulant or anticardiolipin antibody, you want to make that diagnosis because those patients need to be on warfarin. They do better with that. So if somebody would say lupus who has a blood clot, you're worried about that. That's something you want to rule out. One more question from you.
Can you talk a little bit about IVC filters?
Filters, as a whole, there are too many put in. They use retrievable filters. The idea with a filter, you put it in, you want to get it out. There's certain acute indications, somebody coming in with DVT or PE and they're actively bleeding, or they clot even though they're anticoagulated, or you start anticoagulation, they start bleeding, you're going to stick in a filter. But once everything quiets down, you want to get them out. Okay, this is old information, but years ago they were putting too many in, and often these are put in one hospital and patients were followed up somewhere else, and they've had these filters placed for too long. They're using retrievable filters, And for the vast majority of patients, it's temporary. And you have to think, when you're putting it in, you have to think when you're getting it out. Question?
In terms of diagnosis, what are the major things that we could look out on, and anything that you've noticed that's not as straightforward?
Well, by diagnosis?
Yeah, I know tachycardia,
Well,
that sort of thing.
tachycardia, that's something you have to look at. Those people do worse. You have to think of it. Okay, these people can present with syncope. They're usually going to present with something, or hypoxia, and you don't know why. If you suspect it, you got to risk stratify them. Now, in certain patients, maybe, get a CAT scan. If a woman's pregnant, you're going to be a little reticent, although theoretically you could do that with shielding them and lower dose. Or somebody anaphylaxed to die, or they have kidney problems. You can start out with an ultrasound of the legs. That's only positive in 50 to 60% of the patients. So if it's positive, it's helpful. If it's negative, it isn't helpful. You can do a VQ scan. Nuclear medicine was really the classic test until the mid-late 90s. But most of them are non-diagnostic. They're not high probability, and the pilot studies looked at this. But, if you have somebody who's tachycardic or hypoxic, short of breath, and you don't know why, you need to assess them for this. And they know if their lungs are clear, and they're not in heart failure, and they don't have pneumonia, and they don't have COPD, that's somebody you have to think about, All right, we done? So that, my friends, is the last lecture on Team 3.